So without further ado, I'll introduce our first speaker for today. Dr. Stan Sonu is an assistant professor of internal medicine and pediatrics at the Emory University School of Medicine in Atlanta. His expertise and research interests include prevention of adverse childhood experiences, trauma-informed care, education, and promotion of relational health and resilience in pediatric primary care. And he also supervises internal medicine residents in the primary care center at Grady Memorial Hospital and provides direct care for children and adolescents at the primary care center at Hughes Spalding Children's Hospital. And additionally, he serves as the medical director for child advocacy for Children's Healthcare of Atlanta. And Dr. Sonu obtained his medical degree at the Medical College of Georgia and completed his residency in combined internal medicine and pediatrics at Rush University Medical Center in Chicago. And he completed a fellowship at Cook County Preventive Medicine and also obtained a master's in public health at Northwestern University. So thank you so much for joining us today, and I'll let you take the mic.
Thank you, Ellen. Pastor John, the screen was working for a second. Yeah, but okay, we'll roll with it. Thank you for Lotus Project for hosting this event. Thank you, Catalyst. I'm pleased to see some familiar faces here. Don, Sandra, Lynn Patillo in the back there. So I look forward to meeting more of us here today and connecting with you all. I am here today to, I think, set some foundation and framing for our conversation throughout the day. And this is a topic, adverse childhood experiences, it's a topic that I talk about a lot in the spaces I work in, both at Emory, at Grady, at CHOA, Children's Healthcare of Atlanta. And I don't get a lot of opportunity to center Asian Americans in these places that I talk. So I'm really excited today to share some thoughts. I will say on the front end, there isn't a whole lot of literature out there, specifically when it comes to Asian Americans or AAAIs and adverse childhood experiences. So there's some research opportunity we have here. So a lot of what I'll be talking about kind of in the second half of this presentation is more a synergy or summation or extrapolation, if you will, of information from the research, from my own lived experience in this city, in Atlanta, growing up in the South, as a racialized minority, and all observations and current events included. So hopefully it'll pique your interest when we get there. This is a topic that, of all the things I've learned in medicine, nothing has been more impactful to my own practice as a physician, the way I show up with patients. At the same time, nothing has been more impactful for my own health and well-being, how I show up as a partner, as a husband, how I show up as a parent, how I am as a son. And so any chance I get to talk about ACEs, I jump at it, because it's not just about how you show up in your job. This is about how you think about your own life and the experiences that you've gone through and making sense of them. So let's jump in. I have a couple caveats, a couple running themes that I want to offer. So as we move through these slides today, I would love for you to hold some space and think about some questions. What's surprising you? What is inspiring you? And what's moved you? What's touched your heart? I love these questions because this is more than just head knowledge. This is more than just like cognitive information, left brain stuff, rational thinking. The goal in this is to, in a meta kind of way, just be human. And be human in this presentation, which means all of your left and right brains, your mind, body integrated. And so I think these questions kind of help set the tone that way. For any therapists or providers in the room, I want to just say, please rest in this presentation. I think a lot of times we show up to talks and the way we pay attention is We want to get information out of it. That's going to change the way I practice. But I think the real value in talking about a big topic like ACEs is just be. And this is a reminder for us to that fundamentally being human is the starting place that makes the most sense, but that's how we have to show up in these spaces. So more than doing anything, trying to think about how you're going to care for your patient, the next patient you see, I just want to say this is a time for us to kind of check our internal vital signs. All right, lastly, and this is more of like a content trigger warning, when we talk about childhood adversity, we're going to be talking about uncomfortable topics. So I just want to acknowledge that some of this might feel distressing. It is okay if you need to, you can't disrespect me. Like pull out your phone, text, email, or get up, get some water. We have to all, stay regulated as we talk about these difficult topics. So whatever works for you to ground you, please do that. All right, I have an agenda. Just go with me. I don't even know if this is the right agenda. I've adapted these slides. So we'll be talking about a lot of things from the problem to how this relates specifically to Asian Americans to a little bit about what we can do. Now, I will say, since I have an hour or so, and I don't know when we started, Ellen, so just like give me a like a sign if you can. Okay, great. I will probably be spending most of the time building a narrative of the problem. And I know that we have later sessions today, like a panel discussion that's focused on the solution. So out of respect for y'all's time and the later events, I won't dig into that section too much, but we'll touch on it. All right. I came across this quote by an activist, Resmaa Menakem, a few years ago, and I think this quote is such an apt description of how insidious this problem of trauma is. If you can't read it, I'll read it. It says, trauma in a person decontextualized over time looks like personality. Trauma in a family decontextualized over time looks like family traits. Trauma in a people decontextualized over time looks like culture. And the reason this quote hits me is it speaks to when generation after generation of people undergo trauma and they have no support or a lack of support, what we will instinctively do as people, and this is just part of our human nature, is we will adapt. And in that adaptation, we will normalize dysfunction. We will normalize these events. We don't even, and that is not because it is normal, that is because that is how we survive. And so this normalization of trauma is really a representation of our coping response, our coping efforts. And it is not that trauma is okay for anybody. So I think this, to me, really says a lot about what's happened or what's happening in the Asian American community. We are really good at grinning and bearing it, at suppressing. We are really good at normalizing things. Again, not because it's healthy, but because that's what we've had to do to survive. There's also another quote that I have a dad joke where I say it's like from Bob Ross, not the painter, but the pediatrician. And I cannot resist saying that joke every time, so I got it out. You don't have to laugh at it, but I just can't resist. It's like a tick. But this quote I really like as well, and it speaks to the invisibility, but yet the pervasiveness of trauma and adversity. So it said that some years ago, Dr. Ross, as he was the leader of a large foundation in California, he was quoted as saying that of all things that cross his desk, childhood trauma is the #1 public health crisis that is just hidden in plain sight. Trauma is not rare. Adversity is not rare. It is universal, and at the same time, it occurs disproportionately in communities that have often been systematically or systemically marginalized, oppressed, or neglected. And I have some more local data to share on this in a little bit. Okay. This is a cue for me to just mention real quick. This is not a topic that I learned about in medical school. Ellen read this long list of stuff that I've done, and none of that really matters if if I'm not actually caring for people in a way where they are supported in their healing. But the first time I learned about ACEs was when I was in my 4th year of residency training. So I was 3 months away from graduating residency. So I'm out of med school. I've done 4 years of post-med school training. I'm 3 months away from graduating. And that's when I heard about ACEs the first time, and it messed me up. I was jacked up. I was actually angry when I heard about it the first time because it was, first of all, so compelling. I couldn't believe that these kind of data, this research was out there. And what topped it off was I didn't learn about it in medical school. In the time that I'm supposed to learn about how to understand people, to understand disease, and be able to treat it, I didn't get any of this information. And so it was one of those moments where when I heard it, I knew that my career was going to be different. It was kind of a flashpoint moment for me. And yeah, to this day, that was almost 10 years ago now. My career certainly has changed. But here's the one of the grand narratives of trauma, and I think this hopefully is updating soon. Uh-oh, that's strange. Okay. One of the key lessons about the adversity research is what we often see in people as the problem, whether it's a health risk behavior, whether it's some kind of addiction, whether it's road rage or getting upset at the grocery line, at the line in a grocery store. What we often label presumptively as the problem in a person oftentimes represents something else. It represents a signal or solution to a different problem upstream. And I have a story to go with this, but for the sake of time, I'm going to move on. But I just want to set this frame as well as sort of a foundational concept. What we often label as that person needs to chill out, that person needs to change, that person is wrong, what is wrong with them, actually is the wrong sort of approach to have, because oftentimes what we're looking at is the solution or signal. Now, the grand story of trauma is on this slide. What we've learned through a really large and still growing consensus of research, and I mean an abundance of research, not just in one field, not just in public health or sociology or psychology or biomedicine, but also neuroscience, physiology, epigenetics, other sort of core or hard science fields. What they've all shown is on this slide right here, that whatever level you look at on that left side, whether interpersonal, community social, or historical, adverse experiences or traumatic experiences encountered on those levels over the entire lifespan are well-established risk factors for dysregulation of our nervous systems, social dysfunction and behavioral problems, physical and mental disease. And this is what had my jaw on the ground, that something like diabetes could actually have, in part, some root causes in experiences. We're also talking about disability, morbidity over the lifespan, and then most alarmingly, so to speak, would be death, and premature death or preventable death at that. So let's jump in with the ACE study. This is a study that I'm sure many of us here have heard before. And the reason I want to talk about it today is because I want to make the overarching point that when we talk about mental health or health in general, we're also talking about physical health. There is no distinction in the human body between mind and body. It is one system. Now, inside our bodies, we might have different organ systems, different organs that have different activities that are unique to that organ, but no organ in our body operates independently outside of the influence of other signals. So what I found powerful about this study is that it made this very explicit connection between our physical health and mental health through experiences that people go through in childhood. This is considered in the public health world a landmark study, not just because of its effort. It required a lot of coordination between a public system like the CDC and a private health provider like Kaiser Permanente, not just for its scale, it recruited over 17,000 adults, but really for its enduring findings. The ACE study was not the first study on trauma. This was actually, it was published in 1998. And what's interesting is I'm still in spaces today where I'm talking about it and people are like, what? This study came out? I can't believe it. When last year? And when I say 1998, people are just floored. But it was published in 1998. Prior to the ACE study, what we understood, or what the public really understood as trauma, was an event that was limited to people who went through extreme or extenuating circumstances or events. So for example, combat veterans returning from Vietnam or the Gulf War, or adjudicated victims or survivors of intimate partner violence or child maltreatment. But at the time, if you remember, if you were alive in the 90s, if you thought of, think about what was the public's perception of trauma. What did the public really think about who was affected by trauma? And chances are, more likely than not, you will think that, well, just like me when I was a kid, I thought, well, there's some people who are traumatized, but those are special circumstances. But most of us, the rest of us, we have nothing to complain about. The general public is fine. The average middle-class American is fine, right? That may not be explicitly said, but that's certainly what's implied by the way we talk about these events. The ACE study took that idea and completely dismantled it. It completely, it showed a very different story. So what did they do? Well, these researchers, like I mentioned, they recruited over 17,000 adults, and they asked them about 10 different questions that involved adversities that a person could have experienced in the home before the age of 18. And so these adversities included domains of abuse, neglect, and household stress. Within abuse, they asked about physical, emotional, and sexual abuse. They asked about physical or emotional neglect. And then they asked about 5 different types of stressors that a person could experience in the home. For example, mental health problems or a substance use disorder in a family member or a household member, domestic or intimate partner violence against the mother, an incarcerated relative, and lastly, parental separation and divorce. One quick thing I want to add here is that of all 10 ACEs, sometimes I get asked, like, which one is the worst? And it's not like it's a competition. But if I had to say which one is perhaps the most insidious, that goes under the radar, that operates without our awareness a lot of times, it would be emotional neglect. And emotional neglect is a very painful thing to think about. But I highlight it because the experience in childhood of not having your needs known, not ever feeling felt, the experience of not having your inner world understood or attended to by the caregivers in our home, whether that's from an absent caregiver or a caregiver where there's a language barrier or a cultural barrier, that experience of neglect is very, very difficult to pinpoint and identify. And what adults say who experience neglect and have some kind of dysfunction in their lives, what they say in the present day, when they look back on their childhood, they'll say, not, I didn't get what I needed, but they'll say the coping response instead. My parents did the best they could. I didn't get everything I needed, but they did the best they could. And in that kind of reframing of that experience, we actually negate a lot of the needs that were not met in childhood. So emotional neglect, I have some slides on that in a little bit. I think is a very important one for us as Asian Americans to talk about, to highlight. And when we do, and I've been in some settings when we've started to talk about it, it is mind-blowing how common of an experience it really is. Now the ACE study, what's important, before I even show you what it found, what's important to understand is who the participants were. So I mentioned there was over 17,000 adults, and of these 17,000 adults, 3/4 were white, 3/4 had gone to college, and all were insured because they were all recruited through the Kaiser Network. So when it comes to participants in research studies, this was a very affluent group. This was not a group that even the researchers initially thought, like, we're gonna find something real here. This was that group that I would argue probably would serve as like the default or like the reference group for other at-risk populations. And so they were floored when they started to look through the data to see that how many of their assumptions were actually wrong. So the ACE study, real quick before I go to move on, it started around 1995, 1996, and because everybody was recruited through Kaiser, the researchers realized, hey, we don't have to just do this once. We can actually follow these participants forward for about 10 years or however length of time and see what kind of diseases show up or what kinds of morbidities show up prospectively over this course. So in that way, it really added to the strength and the validity of the study. All right, so in that 10 years or so the ACE study ran, it led to the publishing of, 80 to 90 papers. I'm going to condense everything down to three main findings. The first one is this, kind of on the heels of this slide. What surprised the researchers was how common these adversities were. Now, I don't know, what you think about your neighbors or what you think about your friends, but for me, I thought, everybody's life was better than mine growing up. And I had a pretty good life, I thought. But trauma or adversity was not something that I talked about with my friends routinely. I grew up in the church. It's not even something that we talked about in a real way at church. Anytime we brought up a problem, it's like you had to bring up the solution on the heels of that, or say something like God's in control. So we never really understood the nature of the problem, even in church settings. And when I read this study for the first time, I was floored. I couldn't believe how common these events were. Well, how common? When they quantified the number of ACEs each person had, out of these 17,000 adults or so, they realized that 2 out of every 3rd person in that study had at least one of those events or more. About 1 in 8, or 12.5%, had 4 of these events or more. And what they also realized was that if a person had 1 ACE, they were about 90% likely to have a second ACE or more. If they had 2 ACEs, they were about 60% likely to have 3 or more. So it was actually more rare where a person just had 1 ACE and the rest of their life was fine. What they realized in contrast was ACEs tend to occur in clusters. They cluster together. So this, 2 out of 3 people in this study who are from a very relatively affluent group, the fact that they had, this high prevalence of ACEs, it was stunning. And the story goes that one of the principal investigators, Rob Onda, when he saw these data for the first time, he wept. He was just overwhelmed at how common these events are, and yet we don't talk about them. We actually walk around as adults hiding or negating or suppressing the wounds that we've incurred and experienced in the past. We're really good at that. Now, more recently, the ACE study, like I said, was done in the 90s. We have some more recent data on ACEs and the distribution and prevalence of ACEs across the United States. So there on the left is a nationally representative sample of over almost 200,000 people. And you can see here that, the prevalence of ACEs, instead of it being 36% who had 0, 38% had 0 here. Let's see if I can get my mouse. And it's roughly similar to the original ACE study. Now, here on the right, a few weeks ago, I had an opportunity to speak at my church about this. And in the seminar, which was, to my surprise, very well attended, we had about 60 people who completed an anonymous ACE questionnaire. And my church, 4 points, is not socioeconomically diverse, okay? I'm just gonna be real. It is a very affluent, middle class and above church, predominantly of Asian Americans, some who grew up in Georgia, about half, and in the other half who were transplant, who moved to the city in the last 10 to 15 years. And look at the difference in prevalence of ACEs there. 20% have 0, and it's flipped. 1/3 have 3 or have 4 ACEs or more. Now, I'm not gonna, overgeneralize this sample to the rest of Atlanta, but I just want to emphasize the point that even at a church that's very upwardly mobile, that is very financially secure, and we know it, this is the distribution of ACEs. So this is a real issue in the Asian American community. I was floored during the discussion part in this seminar of how common stories of neglect or physical abuse or even sexual abuse. About 25% of our group had experiences of sexual trauma. I was just floored at how common these events were. And there are people in our congregation who have been going to, who have been fellow church members for a long time. They had no knowledge about this at all in each other's lives. Now, building on that, the second key finding from the ACE study, and this is where my blood started boiling as I realized how massive this problem was study after study has shown that the more ACEs a person has, the higher risk they are for a multitude of undesired health outcomes, a multitude. And I'll show you some examples in a second. So from a large scale viewpoint, ACEs are associated with health risk behaviors like smoking cigarettes, early initiation of smoking. They're associated with alcohol use disorder, early initiation of alcohol, more frequent binge drinking episodes. They're associated with illicit drug use, like IV drug use and high-risk sexual behavior. Then ACEs are related to mental health conditions that have a kind of threshold criteria for diagnosis, so depression, anxiety, PTSD, a history of suicidality, and bipolar disease, schizophrenia. And then ACEs are related to some of the most common things that I see in primary care. The physical health problems that are the most alarming in this country for adults actually have some kind of contribution from early adverse experiences. So we're not talking about rare conditions. We're talking about things like heart disease, stroke, COPD or chronic lung disease, cancer, diabetes, autoimmune disease, chronic pain. And then the researchers found that ACEs are related or associated with a whole host of other socially important outcomes that can influence health over the trajectory of life. So poor self-reported health, disability, premature mortality, unemployment, financial stress, delinquency, in and out of school. So from this list alone, I hope we can appreciate that when it comes to health and when it comes to thinking about how our early life experiences shape our health, we can't just focus on one mental health condition like depression. We can't just focus on anxiety. There has to be a sort of global view of health because I will say as a representative from health systems, we don't do a good job of providing holistic health. We might do a good job of saving someone from the brink of death, but when it comes to promoting health and flourishing, understanding all of the inputs that contribute to it, we're just not there. And it is really frustrating for me. I encounter this every single time I see patients at Grady on our general medicine floor. I experience this every single time I do primary care in my pediatric clinic. There are some things that we are just not built for, and it's a work in progress. All right, so this is a list, and I don't expect you to read it, especially if you're over there, but just look at all the rows if you can. There are a lot of different outcomes that have been linked with ACEs. And this is not even an exhaustive list. This is just the most strongly associated outcomes downstream from ACEs. So these are in adults, and here we have a similar list, but in children. And in children, what I'll sort of highlight or distinguish is that one of the most common ways adversity manifests throughout childhood is not in chronic disease like adult onset heart disease, but it manifests through developmental problems, behavior problems, academic problems. And that really reflects what's happening in the brain or the brain's response to unmitigated, unsupported adversity. This is a slide that kind of shows the same thing in a different way, but when you look at each sort of disease specifically, and you look at, in this study, what they did was they took people who go to a primary care clinic, large sample, and they isolated people by the diseases they had. And then they asked about ACEs. And what they found was that for someone who has PTSD, their mean ACE score for those participants was over 10. Substance abuse, depression, anxiety, you can see it go on down the line. People who have diabetes, the average ACE score in this study was over 4. Heart disease, arthritis. So no matter which way you look at it, it is very difficult to avoid this finding, this recurrent narrative, this theme that there's something about our early life experiences, our childhood experiences, that if they are adverse, traumatic, and we don't get the help we need, they can show up in other ways, whether we realize it, whether we're aware of it or not. Now, if ACEs are common, the first key finding, and if the second key finding is true, that ACEs are associated with negative health and well-being, at some point, we should see on a population level it affect our lifespan. And one paper out of the ACE study series looked at this specifically. What they did was they followed the participants forward, and as they did, they kept track of death certificates, and they saw who passed away in the study period. And for those adults who passed away who had an ACE score of 0, their average lifespan was about 80 years. Pretty good, pretty similar to the average lifespan in San Diego where these participants were from. But for those who had 6 or more ACEs, their average lifespan went down by 20 years to 60. And this disparity, if you think about it, the measurable difference between these two groups is what they experienced before the age of 18. This is completely agnostic to whatever they experience, what additional traumas they experience after 18 or protective factors they experience after 18. And so just from that difference alone, to see an average difference of 20 years, this is a big problem. And this is a disparity that you can't easily identify by geography or county or race, ethnicity. This is a disparity that sort of cuts across all sociodemographic lines. Now, one thing that I think is important to highlight when it comes to ACEs in the original ACE study is that it only asked about experiences that occur in the home. The original ACE study did not ask about any kinds of adverse experiences that occur outside the home in the community or society or even historically. And one thing you realize when you start to dig into the research around ACEs is that there are a lot of things that occur outside the home that are important, but the things that occur outside the home can also be related to what's inside the home. So I like to use this illustration we call the tree of ACEs to make this point. So imagine with me the leaves and the branches here represent the conventional ACEs that we just talked about: abuse, neglect, household stress. As a tree grows, it's growing out of a network of roots that provide the foundation for the tree. And so here we call the roots adverse community environments. These are things like violence in the community, poverty, racism, discrimination, joblessness, economic disinvestment. In and of themselves, these are not good for our health. Even public health has demonstrated that in well-designed studies. But as they relate to the leaves and branches, the conventional ACEs, these adverse community environments, the things in the roots, are thought to confer this kind of contextual pressure or scaffolding out of which the ACEs in the home occur at higher frequency, higher severity, or most commonly in the absence of a helpful resource. So the example that I always cite here is if I have a patient I'm seeing at Grady, and they're from some county that's not Fulton or DeKalb, but they're from like Clayton County, and they're unfunded, they don't have insurance, and we've made a diagnosis of depression or PTSD, and they're like, I want help with this. Like, I'm through with this. I want help with this now. Just because they live in the wrong county, they have the wrong zip code, that eliminates a whole list of resources that I have. So that's how poverty can compound what's already happening at the level of the leaves and branches without that person having any opportunity to do something about that. So there definitely is a relationship between the adverse community environments and the things that we see in the home. Now, to go one step further, as a tree is growing, the roots are spreading through the soil and they're drawing in minerals and nutrients to help grow the tree. And so we have to think about what is in the soil. And we refer to this level as adverse collective historical events. I've put examples here in relatively recent history. I probably would add the war between Israel and Palestine, Russia, Ukraine to this as well. But this is not some, unbased, unfounded theory. There is good data, albeit it's difficult to study in humans, but if you follow the field of epigenetics, there's some really compelling evidence there, some really compelling research that has suggested that the experiences of trauma can affect our epigenome, not our genome, but our epigenome, the sort of access points to our DNA, and which regulate what's transcribed and made into proteins and then go into cells and enact their cellular function. There is some kind of influence of experiences on our epigenome that then could be inherited across generations. And so we might be dealing with, especially, just to center Asian Americans for a second, a lot of us come from not too distant histories of war and conflict and genocide. And there's no telling right now what has already been imprinted into our biology without us having directly experienced those factors. So that is happening underneath the level of what we're experiencing around adverse community environments and then ACEs in the home. And so all of these levels have to be appreciated, especially if we want to talk about an Asian American community together in terms of how what the best approach forward might be. So I love this quote from Dr. Felitti. He was one of the principal investigators of the ACE study. He realized from the research that actually, that phrase, time heals all wounds, is completely wrong. Time does not heal all wounds. Time can conceal wounds, but it certainly doesn't heal them. And, that quote kind of flies in the face of what every single adult, I feel like, told me growing up. Whenever I had a problem or had an issue that I need to talk through, time doesn't heal all wounds, and the research bears that out. There's something, and then lastly, I hope I've made the case that for a lot of people who go through difficult things in life, that's not just something that happened that doesn't affect them today. It's not just a memory that is unpleasant to think about that doesn't have any bearing on our lives today. In fact, what all the research is showing is that unless we make sense of our stories, unless we know what's happened, unless we give attention to it, keeping things buried will continue to impact us and affect us whether we realize that or not. All right. How much time do I have left? 20 minutes? Okay. All right. I think I'll be good. Okay. So I want to spend a little bit of time just to highlight what is going on here. All right. So what the beauty about the ACE study was that it allowed us to sort of kind of see from a bird's eye lens what's going on with trauma and health. But it didn't really answer at all like there's this link between trauma and adversity and health, but like what is actually happening physiologically in our bodies? What is going on? And so I'd like to unpack a little bit of that in this section. Sigmund Freud, Sigmund Freud's a complex guy. I've written about him a little bit. I've read some of his work. He's a very interesting and complex person because a lot of what he talked about, the id, ego, the sexual stages of development has long been discredited. Like no one practices in psychiatry based on that dogma anymore. And yet, he has made a lot of contributions to the field of psychoanalysis. And early in his career, he was a compassionate, understanding, well-listening physician. And one of his very first studies, he interviewed 18 patients in an asylum in Vienna who all had the diagnosis of hysteria, which is a diagnosis that's pejorative, we don't use anymore, but some men and women. And after interviewing all of them, he sort of famously declared in a grand rounds, he said, all 18 of these patients were victims of sexual incest. And when he said that, no one cared. And in fact, they immediately rejected what he said and told him never to say that again, because some of his patients were children of people who were in the proletariat class. They were elite. And there were some important and unavoidable socio-political implications to what he was saying, that so-and-so's daughter might be a victim of sexual incest. Anyway, one of the quotes that came from that body of work is, he saw a person, he said, "I think this guy is suffering from memories," and how true he was. Now, when a healthy newborn baby is born, there's about, I think the estimate is like 100 billion neurons in the brain. So there's a lot of untapped potential in that newborn baby's brain. But the thing is, a lot of those neurons, even though they're not necessarily connected together. So how do you get neurons to connect together? Well, some of it happens just with maintaining life. You know, as a baby grows, there's some natural connections that develop. But a lot of the brain connections and the way that the direction the brain goes is really dependent on that child's lived experience, their ecosystem of support or lack thereof. And by about 2 years, so in the first couple years, there's a tremendous proliferation of this neuronal network. We call this neuronal architecture or brain architecture, where neurons that fire together are going to be more readily able to wire together. Neurons that do not fire together will not wire together as readily. And we know this from old research. This is a study from the 90s. That's why you see this term welfare on there. We don't use that term anymore. But what this study found was that when they followed patients forward for about 3 years, depending on their parents' socioeconomic status, there were marked differences in the number of words children knew and could say and were using regularly. Now, the difference between these children was not because of love. It's not about love and affection in the home. It would be very problematic to claim that, you know, working class parents love their children more than parents who are on welfare. Like that's a ridiculous claim. What we're seeing here are the effects of poverty and how poverty can get in the way of exposure to words, reading consistently, access to books, access to libraries, so on and so forth. And so even from studies that look at something completely unrelated to trauma, we can start to see differences emerge in children as early as 18 months of life. Now, Bruce Perry, who made this quote, is one of our most well-known thought leaders when it comes to trauma and treatment of trauma. He said that understanding the power of traumatic events to shape the brain helps us to better determine what a child needs to heal. And so I think this is such an apt quote that brings us, that helps us to understand what is happening when someone goes through adversity without support. There's something it does to the brain. And so here are 3 things that I just want to set the stage for before I move on. Number 1, even from the ACE study, we can understand that there's something about experiences that can affect our body's physiology, and the way that happens is through the brain. What we've learned from years of child development research is that brain development after birth is fundamentally experience dependent. Acute adversity or trauma is a profound activator of the stress response. The stress response is a good thing that we're born with, but if that stressor or if the stress response is repeatedly activated, over time, behavioral adaptations are going to show up, and that is just normal. And then there's a specific kind of stress, which in pediatrics at least, we call toxic stress, and that really represents a profoundly dysregulated stress response system that doesn't listen or respond to normal inputs from the body. And so when a child is experiencing toxic stress, there's not just one domain of functioning that's affected. It's not just like behavior problems that show up and that's it, but there's inflammation in the body. So it may make that child's ADHD show up, but also their asthma, but also their eczema, also, you know, whatever learning challenges they may encounter. So toxic stress is not typical stress. It's kind of a special thing, but unfortunately, it is rather common. I think the most important pearl to take away from understanding the link between trauma and brain development is in this statement, that the behavioral patterns that arise from ACEs or trauma are normal reactions to abnormal events. And I wish we could just like unpack this statement for the next hour and a half, because I guarantee us, like if we really understood this statement, we would make sense of a lot of the dysfunction that we see in our society. This statement alone has grounded me, has deepened my well for empathy in ways that I found lasting more than any other sort of approach or framework that I've heard about. When we are stressed, when we go through trauma, we will always come out the other side with some kind of adaptation. And whether that adaptation is healthy or not, it doesn't really matter. It develops at the point in which it helps that person survive that experience. And tragically, a lot of times those reactions are not pro-social. So for example, hypervigilance. If I felt threatened going to school every single day, and the only way that I felt safe was I had to appear mean, nasty, and don't come across me, then when I become an adult and I'm 35 years old and a coworker says something to me that I feel disrespected by, and instinctively I'm gonna go back to that hypervigilance which protected me in my youth, and it's gonna show up non-specifically against a coworker who has no idea where that's coming from. So that's just one small example of how a behavioral adaptation can be carried forth if we're not aware of it, if we're not aware of why it developed. We'll think it's just a part of who I am, it's how I was born. So let me talk about stress. Stress is universal. It's a normal part of the human experience. It is not inherently a bad thing. In fact, our brains were designed very well to deal with stress. So if we were all like in a village together and we came across this animal, right? Suddenly our eyes are like, ho, and we recognize, okay, this is a threatening situation. Like we gotta get away from this grizzly bear. And inside all of our bodies, the stress response system activates. And when that happens, from our brainstem and our amygdala, there is activation of our sympathetic nervous system and HPA axis. The sympathetic nervous system is the stress response. And so inside our bodies, we have a very rapid release of stress hormones like cortisol, epinephrine, adrenaline, cytokines, and they go to our various organ systems and they enact a function. There's a change in activity. So if we see the bear, all of us immediately, our heart rates are gonna go up, our lungs will dilate kind of in preparation to run or fight. Our muscles, we're gonna have more blood flow to our muscles per unit of time, whether to fight or run from the bear. You all can fight first. Like I'll see what, you first. I'm running, but not first. I'm wait to see. But inside all our bodies, these are the things that happen. But what you might see in your neighbor is it can vary. It's not all the same. There's a variability there. So some of us, like I said, might choose to fight the bear. DJ, you first. But you got it, man. Others might choose to run from the bear. Pastor Jen, you first. You're the farthest along, right? But children, if we can't fight or flee, children will often do this third option, which is to stay put and freeze or dissociate. And that is also the brain defending itself, protecting itself from the awareness of the trauma as it's happening real time. And too often we hear about stories where people who, when they're experiencing interpersonal trauma, a sexual trauma, their stories of how they recollect, how they remember the event is they are not there. They're kind of out of body and they focus on some object. And that memory is just fragmented. And that is not because they're not trying to remember it on purpose, but because what the brain is doing is going into a self-protection mode. Now, when trauma is common, when adversity happens in childhood without support, these stress responses will eventually transform or become behaviors. And these are the behaviors that get us into trouble, that are problematic in social settings. So the fight response can become hypervigilance, where either you get aggressive, rageful, or really anxious in response to a stimulus that feels threatening. The flight response can become avoidance, where when we're confronted with a problem that's stressful, what's worked in the past is just to run away from it and ignore it. That's not solving it, but it's just to not deal with it. So like a kind of procrastination to dealing with problems. And that's not a part of a person's personality. It's a learned response outside of consciousness. The freeze response can become dissociation. And I until I learned this, I didn't realize, anytime I was talking to a patient, sometimes what would happen is I'd be giving them an important update about their condition. And one time I remember I was talking to someone, a young woman, about a mass found on her uterus or ovary. I forget specifically which one it was, but as I was talking to her, I could see her eyes widen, and then all of a sudden, she pulled out her phone and started playing music. And I remember at the time feeling so disrespected that this person, as I'm talking about this really important thing, would pull out her phone in front of me and play music. But what was happening, thinking back on it, was that news was so distressing that her brain automatically went to the thing that helped her regulate in the past. She wasn't playing a song to disrespect me. She was playing a song because she had to do that to get off that realization that there could be something really serious on her uterus. Now, there's one more response as well, and this tends to happen in more extreme circumstances, but it's the fawn response. And I just put this on here. The fawn response can become an accommodating sort of orientation. I put this on here because I think, one, it's under-recognized, but two, I think this could be relevant to our conversation when it comes to Asian Americans. Okay. So toxic stress, just real quick, I want to get to the Asian American part, or the part where I'm sort of centering Asian Americans in this. Real quick, I just want to show you, we have imaging data that can, where we can actually see the effects of trauma, abuse, maltreatment, real time on brain function. So the child so this is a person who's laying on a table in front of me with their feet pointed up, feet pointing towards you and their chest up. And it's an axial cut. And wherever you see red is where it implies brain activity. And so on the left, there is a child who was raised in a nurturing environment. When given some prompt to activate the temporal lobe, you see a lot of red. But in that same cut, for a child who had been abused for her early childhood, experienced abuse and maltreatment, when given the same prompt, you see much less activity in that region. Imagine the implications on learning, on reading, on sensory awareness that child might have on the right. This is a more extreme example of neglect. This is a CAT scan of 2 children who are 3 years old. The one on the left raised in a nurturing environment. The one on the right raised her entire life in a Romanian orphanage where they were never picked up. And so you can see here just the difference in the brain volume. You don't have to be a radiologist to appreciate the difference. Now, both of these children were of the same height and weight at the time they were born and at the time of when the study was done. So it wasn't because of a nutritional difference that accounted for the difference in brain volume. All right. If I have time, I'll come back to this one where we just talk about some more specific brain regions that are impacted by stress and trauma. But for the sake of time, let me move on. Okay. I want to highlight a little bit about intergenerational trauma. Do I have until like 11? Is that okay? Okay. Intergenerational trauma. And this is, I think, something that, again, is difficult to talk about, but if we want to heal, if we want to move the needle on our mental health as a community, we have to start with, we have to have a willingness to understand our stories in ways that we still don't understand very well. And I've heard from my friends and other Asian American people I met, colleagues over time, where there's a kind of a refrain, especially if we're from like an immigrant household, where my parents don't talk, my grandparents don't talk. We don't, I can never really talk to them about this kind of thing. And the last time we tried was, 15 years ago or 10 years ago. I would say that there are so many things in our stories that we can learn about that can help us make sense of our lives today. And I found that to be especially true in my own life. Intergenerational trauma is the cumulative emotional and psychological wounding transmitted from one generation to the next in the absence of direct exposure. What's important to know about intergenerational trauma is that it's a part, not the whole, of a person's story. It doesn't have to happen with intention. It's not a dynamic that imparts effects all the time. And it may not always reach the level of being problematic. But that being said, it's an important thing to acknowledge. And so here's one way to think about it. In the grandparents' generation, you might have experiences of war, famine, displacement, racism, persecution, extreme poverty, PTSD, and addiction. And if those experiences happen and that generation doesn't get help for it, and they have children, what the children might experience is the silence around their parents' experiences. So what the children might experience is neglect, abuse, silence or denial, abandonment, which can lead to or be compounded by addiction. And then these children grow up to be adults and they have their own children. And now in this current generation today, what children and youth are experiencing are unprecedented rates of depression and anxiety, or things like imposter syndrome, burnout, and addiction. And what I want to emphasize here is that in this chain I'm not even talking about intention. It's not about intention or lack of intention, if they're doing this on purpose or not on purpose. These are dynamics that occur with or without our awareness. But with our awareness, we actually have a chance and opportunity to break that chain of trauma. The way it happens, and this is just kind of a summary slide, there's epigenetic phenomenon that can increase generational vulnerability on a biologic level to adverse experiences. Attachment, I kind of skipped over that slide, but parental attachment, early life attachment can certainly impact how a child develops and has a sense of self. Toxic stress, which can dysregulate our stress response system or represents a dysregulation of our stress response system, can certainly contribute to health problems through inflammation. And then learned behaviors. So I remember taking care of a 30-something-year-old bartender at Grady who was admitted because he was vomiting blood. And turns out that he was vomiting blood because his liver was very sick. His liver was very sick because he drank a lot. And when I talked to him, I was like, hey, what do you think about your drinking? Do you think it's, is it causing problems? I never assume. And he was like, no, my drinking is not a problem. I'm a bartender, so people buy me drinks. It's an occupational hazard. And then I asked him, hey, growing up, he told me he had two parents, he had a great childhood, and I said, okay, well, hey, growing up, how did your parents solve problems? Like if they got into an argument or they were stressed about something outside the home, like what did they do? And what he said was, oh, they drank. Like every time they were stressed, they drank. I remember even like at 6 or 7 when the earliest memories I have, my parents drinking whenever they had a problem. And the next day I come back and he said, he tells me, Doc, you messed me up, man, because after that last thing we talked about, I started thinking and I was like, I don't know any other way to deal with stress. I just drink instinctively. And he said, I called my mom after you left. We had a conversation, and they actually told me they were worried about my drinking and that it was a problem in the whole family, and that my mom is actually going to help me go to rehab, and she's going to help me financially and help pay for it. And so in a span of like 12 hours, this guy went from complete denial to I need help, and here's how I'm going to do it. And I didn't use any kind of model of behavior change. I didn't label him as contemplative or pre-contemplative. I didn't use, some kind of fancy framework. I just met him where he was and just asked him questions. And it turns out that he realized those learned behaviors were especially problematic. All right, the human brain is neurobiologically designed for relationships, but we have invented contexts that are relationally impoverished. I think this is really important for the Asian American community to appreciate. I think we, and not to go down the route of stereotypes, it's my impression that I think we treat social or relational isolation as normative. And not because we like it, not because we think it's good, but because that's how we've adapted in a country where, and I'll just speak personally, growing up, even though I made good grades, even though I was okay at sports, even though I tried to show up in the best way I could, I still lacked a sense of belonging and being in the fabric of a community. And I felt like the distinctive point there was my Asianness, that I was a foreigner, that I wasn't someone who looked like a typical American in the 90s. We all remember, and as Marvin talked about, we're on the eve of the Atlanta spa shootings of 2021, where 6 of 8 people who were killed were of Asian or Asian American descent. And on the heels of that event, there was a lot of conversation, I think that was good, in raising awareness about anti-Asian American bias. This is a quote from Stephen Yeun, the actor, that some of y'all might have seen this article, but he said that, "Sometimes I wonder if the Asian American experience is what it's like when you're thinking about everybody else, but no one is thinking about you." I think this, for me, when I read it, I actually teared up. It struck a chord with me where I realized he said something that I had been thinking about for a long time but never could put into words, that our pain, that one of our shared experiences in the Asian American community is not this direct kind of abuse necessarily, or kind of oppressive marginalization that perhaps other oppressed peoples in our country have experienced. Our pain is, it kind of comes downstream from just being forgotten, being relegated as unimportant. It's a different kind of dehumanization, not one of being rendered as an animal, but being rendered as an object or being subhuman, to not have your concerns cared for. Asian Americans notoriously don't access, or we are less represented in behavioral health or mental health resources. And I think this slide real quick can kind of paint the picture why. Right now, when it comes to mental health problems, the way that what's standard in our country is that you need criteria to meet a diagnosis. And so to have PTSD, you need hypervigilance, you need re-experiencing, you need all these kind of criteria, and then if you exceed it, then you have the official diagnosis. But that doesn't mean that mental health lives on this discrete on or off kind of spectrum. Mental health is a continuum. And I think for Asian Americans, we, in our, call it cultural legacy, call it the way that we've survived and always survived in this country, I don't know why, but we figure out ways to compensate, to suppress, to keep showing up to our jobs, keep showing up to things, even when we might cross the threshold and have an actual diagnosis that could be made. But a lot of times I think we kind of live at this level down here, where we're below that sort of threshold symptomatically for diagnosis, but we're far from feeling like we're flourishing or doing well or feeling healthy. Okay, now I'm really out of time, but I'll wrap up with the couple last slides here. So where I land here in terms of one of the things that I think as Asian Americans we should talk about more is this tension of neglect and invisibility. I think this shows up on multiple levels: societally, historically, culturally, in our families. And I just want to spend a little bit of time talking about that. I already said this before, so I won't belabor the point, but how adults talk about with histories of emotional neglect, how we talk about our childhoods is, my parents did the best they could, and yet we have few memories or stories of intimacy and being known. Now, neglect also lives on a spectrum, and when we think about neglect, our minds might jump here to the child who's been severely deprived and needs to be replaced or rehomed through the foster system or adopted. But other kinds of neglect can also affect us that are a bit more insidious and seem milder in nature, but they're just as impactful. So inconsistent parental responsiveness, a lack of attunement, a lack of having your needs known or met, a lack of support or belief in abilities. And I can't say how common, over time I've realized that one difference perhaps that is unique for Asian American women versus men is that, and my wife will allow me to share this, but growing up, she was never told that she could do hard things. She was never told to go out and pursue what you want to pursue. She was always told, play it safe, be conservative, don't raise your head, don't be a hammer, or don't be a nail that needs to be hammered down. Whereas my parents were like, what are you going to do with your life? What are you going to accomplish? And so for both of us, that was problematic in different ways, but I think there's something about when a child doesn't hear those words of affirmation, when a child doesn't hear that encouragement to go out and pursue, I believe in you, that can leave a lasting impact. There are studies that have looked at neglect. Neglect can be a greater threat to development even more than abuse. So this study found that when it comes to the domain of creativity, that people with neglect had the lowest scores compared to those who even experienced physical or verbal abuse. For those who, when they measured confidence and assertiveness, those who had experiences of neglect scored the lowest when it came to that measure. So, and then I'll stop on this slide, just out of respect for time. So, I'm sorry for going long. But here's how it might show up on a behavioral level today. One, we might have difficulty accessing our emotions. Why is it hard to access or getting into our emotional space? Is because as a child, whenever they had an emotional need, it was unacknowledged, rejected, or pushed out of them. And so a lot of us have grown up feeling like emotions are bad or dangerous or something to be ashamed about. And we don't attend or cultivate an emotional life, which really is detrimental to our self-awareness. Perfectionism, that is has huge connections to experiences of neglect. And how? Well, if I grew up in an environment where I was only accepted or I was only okay in my parents' eyes if I was perfect, then that becomes sort of the way that I can create a predictability of love. In contrast, so if I'm perfect, I can sort of guarantee what love and affection comes towards me. And when I'm not perfect, what that means is I'm worthless. I have, I'm full of shame. I have nothing to contribute or offer. And so perfectionism is, I think, a downstream consequence of neglect. There's relationship challenges, the revolving door of guilt and shame and self-absorption, having a low self-esteem, default self-critical view, people-pleasing behavior. These are all sort of downstream consequences of neglect. Okay, so I will stop here. If there are any questions or any comments, I'd be happy to hear them now. But thank you so much for your time. I'm sorry I couldn't get to some of the ways that we can go against what's happening here, but I know that we have some activities later on today that'll touch on that. So thank you so much.